Good evening, everyone. I am Dr. Suresh Kumar Jalupalli, consultant pulmonologist at District COVID Hospital, Kadapa, and associate professor at Fatima Institute of Medical Sciences, Kadapa. I am moderating today's masterclass on GINA guidelines. A warm welcome to all the participants on behalf of Chest Council of India. Global Initiative for Asthma was launched in the year 1993 with the collaborative efforts of National Heart, Lung and Blood Institute, World Health Organization and National Institute of Health, USA. The main objectives of GINA are to increase awareness of asthma and its public health related consequences, to reduce the mortality and morbidity of asthma, to improve management strategies for asthma, and to improve availability and accessibility of effective asthma therapy. Since the year 2002, the GINA report on global strategy of asthma management and prevention is being updated annually. The latest recommendations in 2020 GINA report may be considered as the most fundamental change in asthma management since the past 30 years. With this brief introduction about GINA, I would like to introduce today's topic master, who is well known across the subcontinent and is considered as the Maharati of airway management. Dr. Rajesh Varnakar, a name that needs no introduction among the pulmonologists in India. Dr. Rajesh is the Director and Chief Consultant Pulmonologist at Getwell Hospital and Research Institute, Nagpur. He is also the Principal for the Academy of Ethical Clinical Research Training, and he is the National Editorial Board Member for Lung India Journal. He is the Director for Unique Clinical Research Private Limited. He is Principal Investigator for many research studies in asthma and COPD. He had many publications in national and international journals to his credit. It is my pleasure to invite Dr. Rajesh Varnakar, who will be enlightening us regarding the updated GINA guidelines in detail. Over to you, sir.
Thank you, Dr. Suresh, and thank you, Chest Council of India, for having me today for this important topic of dealing with GINA Report 2020. And before I start my lecture, I would like to have some disclaimers. Like, I am no topic master at all. I'm still learning from my patients, and this pandemic has really emphasized this fact very much. And second, that I would be dealing with adult, actually, GINA report. And third, talking about the semantics, I would like to tell you that the topic of the webinar is basically the GINA guidelines, but the GINA itself doesn't say that it is actually guideline, but it is called as GINA asthma strategy, or we call it as GINA report 2020. And this is what the GINA itself says about it, is that the GINA report is not a guideline but an integrated based report or strategy which focusing on translation into clinical practice, whatever is given in this report. And recommendations are framed not as answers to isolated PICO questions that usually happens when we formulate a basically guideline. But whatever given is in this report is a part of an integrated strategy in relation to the GINA goals of preventing asthma deaths and exacerbations, as well as improving symptom control. And it emphasizes on current understanding of the underlying disease processes. It's basically whatever is the human behavior related to asthma is also emphasized in this report, which includes that of health professionals and also patients or health caregivers. It encourages us to implement this directly into the clinical practice, and whatever recommendations are given or whatever facts are given, we can easily translate them straight away into our clinical actually practice. And it has been based on understanding that there is a global variation in populations, health systems, and medication access, and hence GINA provides practical resources for clinicians. And if you have read this report, in fact, you can see that the figures and tables about implementations of various facts given in the report in clinical practices are not just what, but also it emphasizes on how to really carry out these into a clinical practice. So it basically encourages you to directly inculcate all these which you can do in your practice straight away. And why they have continued, as Dr. Suresh has said, that this was basically an implementation of collaboration between WHO and National Heart and also Lung Blood Institute, which published this report first, and then they found actually basically the survey of GINA assembly members in 2017 strongly encouraged development of a practical resources about severe asthma and how they did it. And why this was needed was it was felt that there are limitations of current resources about severe asthma that are available in the domain. So as we all know that guidelines are costly and time consuming to develop and also to maintain, because once they are formed, basically they are to be updated. So typically guidelines undergo a very tedious process of initial development, and then they are left to it, and then maybe they are there with infrequent updates, so that so many, and this is of scientific material is such a resource which keep on changing every year, but there are infrequent updates, and actually we don't know what is of course the latest if we just depend only on the guidelines which are made once and then rarely or very infrequently updated. Then conventional evaluation of evidences places a high importance on internal validity. So guidelines are those which basically takes into account the various evidences, and basically recommendations may not be generalizable to patients seen in normal clinical practice. And guidelines are often written in academic language, and evidence is typically compiled as answers to individual PICO questions, which is a framework of constructing research questions in guidelines, which deals with population intervention, control outcome, and the time period for which it was framed. And hence it may have a limited relevance to day-to-day clinical practice. And lately we are seeing that much of current literature on severe asthma focuses on actually biological basically therapies, and we all realize that there are many more patients with difficult to treat asthma than with severe asthma, and clinicians need practical advice about how to distinguish these patients, including in primary care. Advice is also needed by clinicians in areas where biologics are not advisable or affordable, because when we see these guidelines, you see that these are the end, what we call requirement that we should have biologics for every patient, and which is quite difficult. So there is a question mark whether these are just commercially driven or something. So I think it is better to rely on GINA, which actually categorizes these patients and also tells us if it is not available, what else we can do. So coming back to my lecture, what I am going to do in this next 40 to 45 minutes is I'm going to tell you about the GINA strategy. We are going to have a breaking news kind of thing in GINA, which is new approach to intermittent and mild asthma therapy. We will see the timelines at how GINA report has basically positionally changed the basically place of short-acting beta agonist. Key changes in 2019. We will see the proper GINA 2020 report as applicable to adult patients. We'll have a brief discussion on what's new in GINA 2020, and then we have the concluding remarks. So, over more than 20 years, the Global Initiative for Asthma has regularly published an annually updated global strategy for asthma management and prevention that has formed the basis for many national guidelines. So it's sort of mother of our national guidelines, if not the guideline. It has got much more, I think, place, higher up place in this what we call global asthma resources. And if it is not guideline, it is actually mother of various national guidelines, because based on these facts which are given in the report, various basically nations make the guidelines. So, and this GINA report is based on what they understand as goals of asthma treatment, and it can be divided into symptom control, which takes into consideration that the patient of asthma should have fewer asthma symptoms, they should not have any sleep disturbance, there should not be any exercise limitations, and they consider the future risk reduction of these patients. So not only symptom control, but how to do the risk reduction in terms how to maintain the normal lung function, how to just do the risk reduction of prevent flare-ups or exacerbations, how to prevent asthma deaths, and how to optimize the treatment and also avoid medication side effects. Uh, and it also considers that the patient goals may be different from these, and these also has to be understood by the patient, and to also make him understand that these are the goals which is going to basically make him life quite easy to lead even if he has asthma. And symptoms and risk may be discordant, and we need to assess both. For example, patient may not be much more symptomatic, but still he may be at higher risk of having exacerbation in future, and this has to be understood. So this is a roadmap of basically the guidelines which is there and which came into 1995. As I've told, they are periodically updating it, and now in fact they are updating twice in a year, so that we don't have to wait much for any updates to be adopted in clinical practice. And the major revolution has happened around the use of short-acting beta agonist, which is the breaking news of 2019 and 20. And so, as happens in all the news channels, you get to know the breaking news first. So I am doing this in this webinar. That breaking news for GINA 2020 report is that there is a new approach to intermittent and mild asthma therapy, and it has been basically compared akin to evolution or revolution in the GINA guidelines or strategy. So what has happened is that due to safety concerns, GINA experts no longer recommend treatment with a short-acting beta-2 agonist alone, and they have recommended that henceforth all adults and adolescents, but not yet children. But then this may happen in future guidelines that even children will be included in these of recommendation, that with mild asthma they should receive either symptom driven or daily low dose inhaled corticosteroid. So main goal of this new approach is to reduce the risk of serious asthma exacerbation and asthma related deaths in the population of patients with mild asthma. So if you can see the timelines of this basically short acting beta agonist position changes in asthma management, we find that it was in the year 1995 that GINA basically had first publication, and they said that SABA is a first line rescue medication. It can be used as monotherapy at first treatment step, but even during that time it had warned against regular use of basically short acting beta agonist very frequently. Then there was a first revision in 2002, and they continued their warning, but now formoterol was added in basically this rescue medication. And then again there was a second revision in 2006 where there was a passing by mention of SMART regime, which gives a combination of budesonide and formoterol use. And the third revision in 2014 really paved the way, in which they basically placed this budesonide, formoterol, or budesonide, or also beclomethasone formoterol in a smart therapy regime, and they placed it in the third and fourth treatment step in patients with frequent exacerbation. And now there's a complete U-turn from what they did in 1995. And as you know, that the key change in GINA 2019 is that it no longer recommends treating adult and adolescents with asthma with a short-acting bronchodilator alone. And this has been there because what they have realized is that patients with apparently mild asthma are at risk of serious adverse event, and they found that 30 to 37% of adults with acute asthma, 16% of patients with near fatal asthma, and 15 to 20% of adults who are dying of asthma, they all reported that they had symptoms less than weekly in previous 3 months. So this really basically gave us a clue that what we are doing is wrong, because, and this was also what we have realized in our practice, that patients do say that they were all right for about a week back and then they just suddenly had this asthma attack. And this is quite much realizable in our clinical practice as well. And plus, exacerbations triggers are quite variable. It can happen over a period of time. It can happen actually suddenly, like basically viruses, in virus infection, pollen exposure, and of course pollution is there in our country. And added to that, it can be also because of poor adherence to the treatment therapy by the patient. So inhaled SABA has been the first line treatment for asthma for 50 years. And this dates from an era basically when asthma was thought to be a disease of bronchoconstriction. And actually focus was there to actually relieve just this bronchoconstriction, and underlying inflammation was not addressed to at all. Patient satisfaction, and we have realized is that patient satisfaction with the reliance on SABA treatment is reinforced by its rapid relief of symptoms, its prominence in emergency department and hospital management of exacerbation, and its low cost. So they get hooked to this short-acting beta agonist, and they don't heed to the advice that you should also take a controlled medication in the form of inhaled corticosteroid. And it was proved that they were actually neglecting this important part, because they get and here the perception basically changes, that patient commonly believes that my reliever gives me control over my asthma. So his control may mean that the immediate control that he gets from short-acting beta agonist, which may not be basically quite safe for him in the long term, because it actually puts him in the risk of getting exacerbation. And hence he also doesn't see the need of additional treatment in the form of daily inhaler of a corticosteroid, and hence basically tends to neglect it. So all these background changes, what led to the risk of SABA only treatment, which was proved to the world, was a series of articles which happened in New England Journal of Medicine, and also the Lancet, which basically proved that regular or frequent use of SABA is associated with adverse effect. And as you know, that it causes beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, and also decreased bronchodilator response. And it leads to increased allergic response from the patient and increased eosinophilic area inflammation. These studies also emphatically proved that higher use of short-acting beta agonists is associated with adverse clinical outcomes, and basically some studies showed that dispensing of more than 3 canisters per year is associated with higher risk of emergency department presentation. And it's very common to see these patients who dispense more than 12 canisters per year, and these patients were the ones who were associated with higher risk of death, and this was proved emphatically in this study. So now we come to the full report of GINA 2020, and I would always highlight it because it's basically a big report of about 150 pages, and I'm supposed to revise it in just next about 30 minutes remaining or so. So just to revisit the diagnosis or the definition of asthma, as we all know that now it is defined that asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory systems, in front of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitations. So these two words are very important definitions: variable symptoms and variable airflow limitation over the period of time. Before I really go to the phenotypes, let me first just a brief description of this terminology of this phenotype, endotypes, and biomarkers. So phenotypes are the observable characteristic of a disease such as morphology, development, biochemical or physiological properties, or its behavior. So patients with an identified phenotype of obstructive lung disease may share a cluster of clinical, functional, or inflammatory features without any implication of a common underlying mechanism. And this will see how asthma phenotypes are classified. The endotype is a subtype of disease defined functionally and pathologically by a distinct molecular mechanism or by distinct treatment response. For example, you can have emphysema due to alpha-1 antitrypsin deficiency, and this is an endotype of emphysema. The biomarkers are defined characteristic measured as an indicator of normal biologic processes, pathologic process, or even a response to an intervention. The potential examples of, for example, I'll give it for asthma is, and of course we'll see it in details in our subsequent slides, of pheno, blood eosinophils, and these are the criteria that we actually define various phenotypes of asthma. So these are the clinical phenotypes which we see in asthma. As you all know, is allergic asthma, non-allergic asthma, adult onset or also late onset or also maturity onset asthma, asthma with persistent airflow limitation, and asthma with obesity. So diagnostic flowchart of how you really go this, I wouldn't go into the details because you all know that patient with respiratory symptoms which are quite typical of asthma, if you see the family history, and also what we call similar symptoms in also siblings, variability of symptoms in between the patient is quite good. These are actually symptoms which are very typical of asthma. You go for detailed history and examination of the patient, and if patient has come to you without any medication, that you can basically go for a PFT test, and you can define this reversibility of FEV1 of more than 12% or 200 ml from I think the baseline, and you have a very straightway diagnosis of asthma. If not, if suppose patient has come into your exhibition, you can still diagnose it, and you can give basically empirical initial treatment, and also review response, and diagnostic testing can be then basically held up till the time that he gets better. If suppose this PFT has come normal, and still from history and from examination you feel that he still can be a patient asthma, then we can have an array of tests like also bronchoprovocation tests, and thus you can establish basically the diagnosis of asthma and treat asthma accordingly. So we also do the assessment of asthma, so particular symptoms, asthma symptom control, and we assess the risk factor, because these are the factors which are going to tell you that patient is going to have asthma attack in near future. So asthma symptom control is assessed by asking the patient his history in the past 4 weeks about any daytime symptoms which are more than twice a week, if he has got night awakening due to asthma, if he is frequently using his SABA inhaler more than twice per week, or else did he find asthma precluding his any activity in of daily life. And based on the responses, we can actually know the level of asthma symptom control, and we can basically define it into well controlled, partially controlled, or uncontrolled bronchial asthma. Then you go on to assess the risk factors for this his poor asthma control, and this actually depends on his lung function, and I think the single most factor which takes this into account is forced expiratory volume in first second FEV1, and you assess the response after 3 to 6 months of treatment and see how much he has improved. If it is not, then this is a poor outcome of asthma in treatment. And then we also assess other factors like additional potentially modifiable risk factors to flare-ups. We can see like medication, if he's on high SABA use, as I told you, then of course does he have any morbidity like obesity, chronic rhinosinusitis, gastroesophageal reflux, if he's got some confirmed food allergy, and if he's got exposure to at home to environmental tobacco smoke, if he's got exposure to some allergen exposure, context of some I think major psychological or also social problems, and some other tests you can do, which we will see in the subsequent slides, which will basically see that he has got additional type 2 inflammations apart from asthma, and which is going to modify it, and he may get actually better with that. So all these factors you have to assess, and you have to assess the symptom control, and the risk factors you have to assess for the poor asthma outcome that can have. And heavy, and if he has any of these risk factors, increases the patient's risk of exacerbation, and even if he has a few asthma symptoms, it doesn't make him basically not prone to having asthma exacerbation. So investigation in a patient who's not who's not getting better, actually despite giving the treatment, is that first and foremost, do not jump into conclusion that it is a very difficult to treat or severe asthma, because there are many factors to be considered before you really label those patients as difficult to treat or severe asthma patients. And these are very, very, I think, what I call fundamental that you do this, because it is frequently ignored in our practice. And first and foremost, what we should do is watch patient using the inhalers and discuss the adherence and barriers to use. Not only just ask them to answer whether they are using it, but ask them to show how they actually use this inhaler. And there are reports that about 70% of patients do not basically correctly do this inhaler technique properly, and they are not adhering. About 50% of the patient do not adhere to this treatment of inhalers when you give it to them as of the prescription. When you have confirmed that inhaler technique is okay and he's adhering to the treatment well that you have asked, he's also regularly taking the treatment, then revisit the diagnosis always whenever you have confusion or when you have difficulty in treating asthma patient. And if you have found that there is no evidence of variable airflow limitation on spirometry, then you can go for other tests, and you can check again by doing the challenge test. There are other tests for also considering differential diagnosis like DLCO or HRCD chest scan to really confirm that this is not something else than asthma. Having come to the diagnosis that this is of course asthma, you try to potentially also remove the possibility of risk factors and assess and manage comorbidities, because it can happen that you are basically considering asthma for treatment, but then you're just leaving other comorbidities untreated. So check if they got other comorbidities like rhinitis, obesity, obstructive sleep apnea, depression, anxiety, which may contribute to asthma symptoms. Having confirmed this, then you see that if you can step up or step down the treatment to the next level, and in this you have to use a shared decision making and balance potential benefit and risk, and you should discuss this with the patient. And if you find that still it is basically you're not able to handle, then there are options. Now we have got severe asthma clinics, and you can refer these patients to them. If it is not treated by even optimizing the treatment, and you have done everything and you have given the treatment for 3 to 6 months and still you see no improvement, or still if he is having exacerbation, then basically you can actually refer it to a specialized clinic. And asthma management cycle for personal asthma care is very, very important. And in control based asthma management, pharmacological and non-pharmacological treatments are adjusted in a continued cycle that involves assessment, treatment, and review by appropriately trained person. So what you assess is confirmation of diagnosis, symptom control, and see if there are modifiable risk factors and comorbidities. You assess his risk. You also assess inhaler technique and adherence, patient and preferences as goals, and you constantly adjust treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, asthma medication. You constantly adjust and provide education and skill training if he is having some having some myths about it. You have to clear it, and having done, you can you can send out the patient and assess him from 1 to 6 months, and again review the response of whatever you have given him as therapy in his follow-up visit, and see for symptoms, see for exacerbation if he has in between, see for side effects, and also check his lung function and see if his FEV1 has improved, and whether he's actually satisfied with the treatment that you have given. So it's a two-way communication between the patient and doctor, and both actually together work together to have the optimal control. And basically you can involve in asthma treatment by actually prescribing the population level versus patient level decisions about asthma treatment. So what does it mean that in each and every step we have got a preferred medication, and which is the best treatment for most patient, and this treatment at every step is based on efficacy, effectiveness, safety, and also proven availability and cost at the population. So this would be generalized basically treatment option at each every step, and you have got a choice to choose between the control option for individual patients. So you can individualize, and you can further individualize the treatment by choosing between the controllers which are given as option, and this should be a shared decision making process between the patient, parent, or caregiver, and we have to just discuss about the preferred treatment that is most suitable for him, and see if the patient has any features that predict differences in their future risk of treatment response compared with other patients. Are there any modifiable risk factors in this patient, or also comorbidity which you have to address? You should make and allow him to make a choice and see what are his goals for his asthma treatment and what are his preferences. They just maybe, basically we have patients who have got stigma about the inhalers, so same of course medication can be given by some other device, he would accept it actually happily. So these are some of the factors that you have to basically also consider for treatment adherence. And of course practical issue is about inhaler technique. Can he basically use the inhaler actually correctly, and the cost and adherence which we have very well experienced in our clinical practice, that if you tend to give them a very costly inhaler, they would try to save it for occasion in which they have much more symptoms, and hence adherence to treatment of course gets affected. If you say to him take 2 times, he would take it 1 time because he's trying to save the cost there. So cost factor also has to be discussed to really make him adhere to the treatment of course regularly. So this is the initial controller and treatment at every step. So we assess, we confirm the diagnosis, we have taken into consideration also the comorbidities. We have seen that he is able to use the device correctly, and then based on the symptoms and also the frequency of the symptoms, you give a preferred actually controller at every step, like step 1, step 2, step 3, step 4, step 5, which is to prevent exacerbation and control system, and then you give him, and then we have other controller options which you can consider depending on individualized need. And at every step you have got a preferred reliever, which I said at the outset of my talk that it is now as needed low dose inhaled corticosteroid formoterol protocol combination. And so if suppose patient has got symptom less than twice a month, this is a step 1 patient to be treated, and he would require as needed low dose ICS formoterol, and he can use it in a frequency depending on the dose from 1 to about 10 times in a day, and it is as needed. When you see that symptoms twice a month or more, but it is less than daily, then you go to step 2. In this case, this is not just as needed, but now you have to give daily low dose inhaled corticosteroid, and here the preference is again to ICS and formoterol, of course, combination. But now you've got option of controller that you can give a daily leukotriene receptor antagonist or low dose ICS taken whenever you take a short acting beta agonist. So there are some countries in which the combination are not available. So combination of both this formoterol and inhaled corticosteroid is not available. So they can take they can take it basically also apart, but of course together. So he has to be said that whenever he takes the short-acting beta agonist, he also take a puff from inhaler corticosteroid inhaler. Then we move on. If suppose patient has got symptom on most days, or also on walking, and with asthma basically once a week or more, then we have got a, like a preferred controller as low dose ICS LABA combination, and other preferable is you can escalate the low dose ICS to medium dose ICS, or you can combine low dose ICS with, of course, leukotriene also reducer antagonist. When you see the symptoms are on most days, or on also waking, and this is just once a week or more, or you have assessed his pulmonary function test and has found that he has got low FEV1 and is not improving, then you can escalate from low dose ICS LABA to medium dose ICS LABA. And here you have got option that instead of this combination of ICS LABA, you can just escalate from medium dose ICS to a single high dose ICS inhaler, and then you can add to it tiotropium bromide, or you can add also LDR leukotriene, also receptor antagonist. When even with this, these patients are not improving, and you see that now we have to use more than this, and it may happen that you may have these patients have basically frequent asthma exacerbation, and you are using oral corticosteroids. So a short course of oral corticosteroids may also be needed for patient who would actually present with severely uncontrolled asthma, and these are the patients who are called as difficult to treat or uncontrolled asthma, or also severe asthma or category, in which case you have to go for high dose inhaler corticosteroid with LABA combination. And these are the patients in whom you can assess if they got type 2 inflammation and whether they are candidate also for biologics, which are available now, or plus minus you can add therapy of tiotropium, anti-Ig therapy, and biologics. This step of 5, you can basically add low dose oral corticosteroids, but you should consider side effects, and this can't go on for long. It's okay to give the burst, but you should basically taper to the lowest dose and find out if this oral corticosteroid inhaler need actually can be attenuated from his treatment prescription. And once you have identified that step and you have given the treatment, this is a constant assessment based on his regular visit, in which you again try to do the assess, adjust, and review response method to then also adjust asthma up and down for individual patient needs. So once if he's on step 1, if you assess that he is not doing well, you can go to actually the next step, or if he is doing very well, and this actually can be done from 3 to 6 months. So at least let the patient be on that step for at least 3 to 6 months. I think usually it's 3 to 4 months, and then you again assess the response. If he has fared well, then you have to basically go for what a step down treatment. If he's not, then you can step up. But all this depends on your assess, adjust, and review response cycle. That is very important, as I said earlier. And the most important is basically, which is not thought of, is guided asthma self-management and our education and skill training, which we impart to the patient. And skill training to use inhaler device effectively is very, very important and cannot be stressed less. Encouraging adherence with medication, appointments, and other advice within an agreed management strategy has to be told to him, and see to it that he actually sticks to his appointment schedules and regularly visits, in spite of the fact that he's feeling well, which is really difficult. And for this you have to give asthma information to him, that how this is the disease and how it fares, and how it is a lifelong management, of course, that we need, and also would need his also discipline and adherence to treatment on his part as well. And this training in actually guided self-management with self-monitoring of symptoms of with a force peak flow meter as well, which we can give to be used at home, and a written asthma action plan to show how to recognize and respond to worsening asthma, and regular review by a healthcare provider or a trained healthcare worker is must. Even if it is there, it's really ideal setup, in fact. And because I feel that this is a very important strategy, I would spend one more slide on this. That strategies to ensure the actually correct inhaler use of the device is, first of all, choose the most appropriate inhaler device for the patient before prescribing. Let him be involved in choosing rather than you just dishing out the prescription and asking him to take what you basically thought as good for him. And also consider medication options available, patient skills and cost. If suppose different options are available, then encourage the patient to participate in the choice. For actually pressurized actually meter dose inhalers, use of spacer improves the delivery and also reduces the potential for side effects. Ensure that there are no physical barriers, arthritis that limit the use of the inhaler, and avoid use of multiple different inhalers types where possible to avoid confusion. So don't give him one inhaler type in the morning and ask him to take another in the evening and then again another to have whenever he has exacerbation or when he's in emergency. This actually leads to confusion and of course will not be actually proper. Uh, at each and every visit, so as soon as you give the prescription, ideally you should have a person sitting outside your chamber who would actually demonstrate and check inhaler technique, and this can be done at each and every review for which he comes, and in fact ask the patient to show how to use the inhalers, and just don't ask what you call theoretically to know how to use it. So I encourage the patient to bring their own inhalers actually every time they come to me to show, and then if suppose I find that he's not improving, I first check the inhaler technique and ask him to take out his inhaler from his pocket and actually show it to me, and this really actually also reinforces that of course something else has to be done if he's doing the inhaler actually technique correctly. And of course if he's not doing it correctly, identify the errors and of course rectify there and there only, and show the patient how to use the inhaler correctly. Physical demonstration is very important with actually placebo inhalers. Check the technique, paying attention to problematic steps, and this happens and you have to be really patient. Sometimes you see, and as I told you that 70% of people, even in spite of being taught, they do not use it actually correctly. So you may have to emphasize it 2-3 times. Just be patient. And of course, consider an alternative device if patient cannot use the inhaler correctly after several repeats of training. Change it. Recheck inhaler technique frequently after initial training. Errors often occurs within 4 to 6 weeks. So this habit has to be reinforced every just now and then, every basically visit that he comes. And confirm that clinician should be able to demonstrate correct technique for each of the inhalers they prescribe. And there is also a device trainer or some of the clinical assistant who can check on this. So now we come to the much talked these days difficult to treat and severe asthma in adults and adolescents. So difficult to treat asthma is asthma that is uncontrolled despite GINA step 4 or 5 treatment, or that requires such treatment to maintain good symptom control and reduce exacerbation. It does not mean this patient is a difficult patient. Severe asthma is asthma that is uncontrolled despite adherence with maximal optimized step 4 or step 5 therapy and treatment of contributory factors, or that worsens when a high dose treatment is decreased. And this is seen in approximately 3 to 10% of people with asthma who have symptoms. And this is basically a diagram which shows that about 24% of the patients are there on GINA step 4, step 5 treatment. Then the 17% would be difficult to treat asthma patients who actually may not have good adherence to the treatment or may not be using the technique correctly. But when you optimize this, then we are left with about 3.7% of severe asthma patients in GINA 4 to step who have got poor symptom control in spite of best optimizing their treatment, despite actually confirming that they have got good adherence to inhaler techniques. Then what you do? So this basically patients of severe asthma can be referred to a specialist care, and in this specialist care clinics of severe asthma, what we again check is about the techniques and whether we can further optimize the all his treatment, check his comorbidities, then consider a non-biologic add-on therapy. You exhaust all the options which are there with you, like tiotropium, even low dose, what you call aminofen derivatives, and also consider non, of course, pharmacological interventions like smoking cessation, if exercise, weight loss, mucus clearance strategy, influenza vaccination to also reduce viral infection if it is causing, if suppose this is the cause for his exacerbation. And of course, consider a trial of high dose inhaled corticosteroids. If you have not used, wait for this response to happen in 3 to 6 months. And if suppose it is still uncontrolled, then of course you label this as a real true case of severe asthma. And if suppose you have given him short burst of oral corticosteroids to optimize the treatment, try to see that if it can be stopped, or if it can be stopped to the minimum dose. And then you, if these patients are still worsening and you see that these patients, if we just basically taper their medication, taper their oral corticosteroids, they again go in for exacerbation or for worsening of their symptom control, or also worsening of their lung function, then we assess this patient for type 2 inflammation. And this means that you do blood eosinophils in this patient and see if it is more than 150. You do also pheno and see if it is more than 20 per part billion. You also do sputum eosinophils if you can. Asthma is a clinical allergen driven, and or if it just needs a maintenance of oral corticosteroids. And you do basically various other methods to really see if these patients are candidate for this type 2 inflammation therapy. And if suppose you find that these factors are elevated and he's not getting better despite of optimizing his treatment and ruling out any other cause, and also also visiting the diagnosis that this is really asthma by actually doing also what you call CT scan, and also bronchoscoping or additional diagnostic measures to really basically establish that this is asthma. And of course nothing helps. You have exhausted trial of tiotropium, you can give a trial of macrolides, which they say that you can give up to twice in a week. And also consider lowering of oral of corticosteroid. If all this fails, then basically we have got options to go for type 2 targeted anti-inflammatory therapy. And here comes the role of actually biologicals. You can consider these patients based on these biomarkers that I have mentioned, and see if you can choose among these biologicals. Basically, you have to do IG, you have to do sputum eosinophils, you have to do peripheral eosinophils, and see which biological would be best. The ideal is to go for the biological which is cheaper if his IG is more. And we give him the treatment for biologic for about 3 to 6 months before we really assess his response. If we see that there is a response, then you can continue it, and you can try to lower the oral corticosteroid dose and see if these targeted biologicals are helping in basically achieving these targets of weaning him off from OCS. If it is, then it's really good. Otherwise, if you find that after 3 to 6 months we are not able to achieve the targets, then of course we can also stop the biologicals and go on optimizing and go on in a process of optimizing the therapy in these patients, as of course described earlier. So these are the biologicals which are available, and there are various webinars which have happened on this and is been focused. At present, we have got omalizumab in our country, which is the cheapest one. We got also mepolizumab, and I think sooner, or I think now we have got availability of benralizumab as well in our country, and there are options that you can choose depending on the cost and the patient's preferences and whether it is available. Taking a detour from asthma management, we come to exacerbation, which is also an important part to consider when you are treating asthma. So exacerbations represent an acute or subacute worsening in symptoms and lung functions from the patient's usual status, or in some cases the patient may present for the first time during an exacerbation, which usually happens with us pulmonologist. The term episode, attack, and acute asthma, severe asthma are often used, but sometimes they can have variable meanings, and patient can differ, and you can differ in actually what is defining what is attack. When you talk to patients, I think the term flare up is preferable for use in discussions with the patients. And basically, before you really give the patient for give treatment to the asthma patient, when he comes to clinic, you should also prepare him for self management of worsening of asthma, and you should give him a written asthma action plan so that he can identify this worsening of symptoms and also lung functions. If you are giving him peak expiratory flow rate to be monitored at home, and basically you can ask him to record his best PAF when he's feeling good, and then refer to it as an ideal measurement, and also compare it when he has a bit of symptom uncontrolled and he's having problems. You can ask him to increase his reliever medication. You can ask him to add also prednisolone 40-50 milligram per day as the first thing that he actually also notices that he has worsening of symptom control. And if he recognizes and acts as per his written action plan, we can actually save him from exacerbation. But if it is not, then we have to we have to manage the severe exacerbation of the patient, and he can come to any primary or tertiary care. Uh, as you get the patient of exacerbation, if he's your own patient, you know that he has come in exacerbation, and then you identify the factors. If he has come for the first time, you have to assess if it is asthma or he has got factors for asthma related deaths. He has got some previous history of exacerbation, or he had admission due to asthma attack previously in ICU. And also severity of exacerbation it can be judged and into mild or moderate, severe, or life threatening, depending on what we see in emergency room. If suppose patient is talking in phrases, prefers sitting to lying down, not agitated, respiratory rate is increased, accessory muscles are not used, pulse rate is 100 to 120, he is having mild to moderate asthma attack, yeah, and he is also having oxygen saturation of 90-95%. If it is severe, he is not able to talk in words, he has to take breath in between, he sits hunched forwarded, he is agitated, his respiratory is more than 30, we can clearly see that he is using accessory muscles for his breathing, his pulse rate is more than 120, his saturation is going less than 90%. And if you find a patient in your casualty who's a previous patient of asthma, and he is drowsy, confused, or is having silent chest, this is an ominous sign that he is having life-threatening asthma attack, and you have to immediately transfer him to acute care facility and do the treatment quite fast. And you can basically, for rest of the patients, so these lab-threatening patient has to be shifted to ICU immediately, while for rest of the treatment, you can continue the treatment by giving nebulized salbutamol, or even if it's not there, it is equivalent that if we give this Sabat 4 to 10 puffs through, I think, a spacer every about 20 minutes for 1 hour, you can start prednisolone either in tablet form or injectable, and you have to give oxygen in the highest concentration available, and assess the patient after 1 hour, see if how he's behaving. You keep the patient. Ideally, the asthma attack patient usually actually recover if it's not life-threatening. They would just recover within 24 to 48 hours. 48 hours, you have to, before you really make this patient discharge, see what has caused this attack and try to prevent it. Assess why did he have attack in the first place, what had gone wrong, whether he has understood his action, and give him action plan if it is not there, and try to avoid the what called future attacks. This would be the complete treatment, rather than just treating the present attack and again sending him back home. This is another new topic which is quite talk is the asthma COPD overlap, or patient with features of both asthma and COPD, which is also called as ECHO. So it's not a single disease, but a descriptive label for patients commonly seen in clinical practice. And as you know, that asthma and COPD are heterogeneous and overlapping conditions. The definition of asthma and COPD are not mutually exclusive. Each includes several phenotypes that are likely to have different underlying mechanisms. This is to be understood. And of course, there is now increased interest in the potential for precision treatment. Hence, we are having a lot of research papers on this, and still we need much more research papers to exactly define and treat this entirety. But you should understand this, that the labels asthma and COPD are still clinical important. And even when you are saying that this is asthma COPD overlap or asthma COPD syndrome, you have to identify whether it is asthma or COPD, which is actually the predominant in this combined overlap. And this is because it entails a very specific pharmacological interventions when you basically define it as asthma COPD, because if you don't do this, they are at risk of attack and exacerbations. So if you see that in this asthma COPD overlap, asthma is of course predominant, then never treat with what we call bronchodilators alone, as we know. If you see that in this asthma COPD overlap, COPD is a predominant component, then you start treatment with LABA and or of LAMA. We don't give ICU, we don't give inhale of course corticosteroids. And patients with diagnosis of both asthma and COPD are more likely to die or be hospitalized if treated with LABA versus ICS LABA. So to be on safer side, always use combination of ICS LABA if you are in confusion which of the two are actually predominant in this overlap, because high dose ICS may be needed for severe asthma, but you have to consider that should not be used basically for COPD for risk of pneumonia. So this is how we really classify the spectrum of asthma COPD overlap, and you identify that in this overlap what is high, whether this is highly likely to be asthma, and you can identify this by knowing the triggers, knowing that this has started before 40 years and of symptoms improve spontaneously with bronchodilators, or if there is already a current diagnosis of asthma or there was asthma in childhood. You see that there is a variable exploratory airflow of limitations. FEV1 change is more than 12%, or actually better if in this overlap you can find out that airflow limitation or FEV1 changes by more than 400 ml from of course baseline. This is much more going towards asthma. On the other spectrum is that it can be likely be COPD if the onset is more than 40 years. Limitation of physical activity is there. There is a persistent expiratory airflow limitation with or without bronchodilator reversibility, and there was no past or current diagnosis or history of childhood asthma. Then you treat this patient as predominantly as COPD. There may be features of both asthma and COPD. Even in these cases, ICS containing treatment is essential to reduce the risk. Add on LABA or LAMA. Do not give LABA and or LAMA without inhaled corticosteroids, and avoid maintenance oral corticosteroids. In these patients, when you have dished out the treatment as per the spectrum, review patient after 2-3 months and review for expert diagnosis. And you can take help of additional diagnostic criteria like HRCT chest and also FeNO challenge test and all those things to arrive at what spectrum is this asthma COPD overlap. So coming to my last few slides on GINA 2020, now what's new in asthma, and no webinar can basically happen without mention of COVID-19, and hence GINA, as soon as the COVID begins, has come out with interim guidance on that. Then it has clarified that advise patient with asthma to continue taking their prescribed asthma medications, particularly inhaled corticosteroids and oral corticosteroids prescribed. There was an initial some guidelines which said that avoid, but this is not there. We have to continue what we were continuing actually in absence of any other adverse studies that come, but as of now it is not there. So make sure that all patients have a asthma action plan. Increase control and reliever when asthma worsens. Taking a short course of oral corticosteroids for severe asthma exacerbations is okay, and ask them when to seek additional help. As far as possible, avoid nebulizers, but this can't be done actually what called blanket banning of nebulizers cannot happen. So if suppose patient is having his home, of course, nebulizer, he has got all the what you call ventilation and all those what you call criteria is fulfilled, and he can actually take it in a room without anybody entering his room for 45 minutes. So all this can be done, but with of course precautions to be corona safe, measures to be taken. Avoid spirometry in patients with confirmed or suspected COVID-19. This is very important. You can basically, and it's okay to empirically treat the patient as asthma for 1 to 2, 3 months, and then again go for what for diagnosis, and we also visit your diagnosis, but don't do it now if you're not sure whether this patient is COVID or not. Follow strict if it is there that you have to do it, then follow strict infection control procedures, because aerosol generating procedures are there, and you know all these procedures now well, and we have to follow it, and follow local health advice about hygiene strategies and use of personal protective equipments and identify mask and all those things when you are doing these aerosol generating procedures, and follow these measures meticulously. In this interim guidance document which came, they have GINA has taken opportunity to also publish additional evidence supporting the role of as needed ICS formoterol in mild asthma, and there are some more studies which are available, and which has found its place in this interim guidance document. It has clarified that when we assess the symptom control, as you must have seen, there is a question of reliever or SABA for symptoms more than twice a week, but this SAMA is not, the one which is ICS formoterol, which has been used as a reliever therapy in all the steps. So even if he has taken it quite often, do not put this as yes in this questionnaire, because the as needed ICS formoterol is providing the patient's controller therapy. But of course, all these things of course will be able to discuss, and they are still gathering the data on it. There's mention of low dose, medium dose, and high dose of different inhaled corticosteroids. So this has been revised to reflect the use of ICS formulation at different doses in clinical practice. This is not an equivalent table, but instead represent the suggested dose of various ICS formulation for the low, medium, and high dose options. And this is the this thing which you can actually consider for various. What is low dose beclomethasone? What is high dose? And this can vary from 200 to 500 micrograms depending on what it is there. And this is what is given as a comparative chart when you say that use low dose ICS, medium dose ICS, high dose ICS, depending on which molecule of ICS you use. This is an intriguing finding that I found in this GINA 2020, having adverse effect with montelukast, and they say that there is a warning now of basically montelukast use, and this box warning includes susceptibility in adults and adolescents, warning nightmares and behavioral problems in children. So before prescribing montelukast, the GINA 2020 report says that health professional should consider its benefit and risk, and patients should be concerned about the risk of neuropsychiatric events. I actually went deeper in this and found that there is only one Canadian study which has been considered by GINA, and I find it quite intriguing because actually I don't know, but we are using it so left and right, and we not found such cases, but I think we should look for it. Maybe we're not knowing it, and now with this box warning coming, because I have seen people taking montelukast for years together and sometimes in combination, and I think it's time that this actually warning has basically cautioned us about use and be cautious about these adverse events now that it is there in the GINA strategy. Other changes in GINA 20 is acute asthma. As you saw, it was written high flow oxygen. Now it is high concentration oxygen. It has emphasized the role of trained lay health worker in asthma education. And this is very good. If you got actually many asthma patients in the clinic, always keep an asthma educator, which really enhances the treatment adherence and also satisfaction of course patient. And obesity has been actually added as a factor contributing to development asthma, as well as the air pollution. New evidence suggests that the 13% of global asthma incidence in children may be attributable to the traffic-related air pollution, and that obesity may be a risk factor for developing asthma. So to conclude, in spite of laudable efforts to improve asthma care over the past 20 years, many patients globally have not benefited from advances in asthma treatment and often lack even the rudiments of care. Many of the world's population live in areas with inadequate medical facilities and meager financial resources. So the GINA Board of Directors recognizes that fixed international guidelines and rigid scientific protocols will not work in many locations, and thus the recommendations found in GINA 2020 must be adopted to fit local practices, and it depends on the availability of healthcare resources. And India needs GINA, because now just one slide which will emphasize this is that with an estimated 37.8 million asthma cases, India contributes to only 11.1% of global asthma burden. Yet, it accounts for over 42% of all global asthma deaths. And in this Asia Pacific Asthma Insights and Management study, which was conducted in 9 countries in the region, reported that asthma management was the poorest in India. And this is all because the lack of awareness about asthma in the community, myths and social stigma associated with it, underdiagnosis and wrong diagnosis of asthma by physicians, poor use of inhalation therapy, and non-adherence to treatment seem to be the major contributors to the disproportionate asthma deaths in India. So to conclude, I would actually exhort all of you to adopt GINA strategy to make your asthmatics patients GINA, that is life in Hindi, easy. Thank you, and thank you for your patient listening.
Welcome back all. What a fantabulous session we have. Dr. Rajesh Varnakar, the master, has presented exclusively and what all we need to know about asthma. In this 45 minutes, we could cover everything. And I remember my journey of treatment of asthma. Like when I used to be postgraduates, like they say, पेशेंट्स के नसों में अमनोफ्लिन की धाराएं बहती थी and decadon shots were given like anything. From that part of the treatment protocols, and because of the GINA, and every year the updating of GINA guidelines and recommendations, sorry. So it has changed the complete picture of asthma management. And now we are way far ahead. After this wonderful session, I invite you all once again for the next most interesting and most happening topic in this webinar, the questionnaire. So, sir, I would like to give the first question to Dr. Rajesh Varnakar, sir. Sir, this is Dr. Rajesh Agarwal from Agra. He was asking how to diagnose and treat occupational asthma.
Yeah, so that's really a good question, and I haven't dealt it in detail in this talk, but we should remember that occupational asthma forms about 15% of total asthma cases that we encounter. And this is there because of the agents that they are exposed to while they are in the occupation. And these occupations are commonly like what called bakers, pyramid dressers, spray paint, people who do the spray painting. We also get it from also farming industry because of the spraying of pesticides, agriculture products, and those who do, I think, weeding work. And in these patients, we should actually evaluate whether, and we can evaluate the history, and this is very important that we ask for their occupation in each and every asthmatic patient and ask about their this occupation and their exposure to these agents which may potentially cause asthma, and also sometimes even he also doesn't know that this is causing, so you have to take a good history of it to really diagnose it. And a typical history that we get in these patients is that they get actually exhibition of all sorts of symptoms only when they go to workplace. So if you typically ask them that if there is a holiday from the work, how are your actually symptoms, and they would say they feel better. So this should give you a clue about this occupational asthma thing. The best the best treatment is avoidance of exposure, or at least also what you call minimizing it. But you should also basically consider that in also non-atopic patients, even if you got a large exposure of these noxious agents, they can have bronchospasm, and this entirety is also described as what we call RADS, or also reactive airway dysfunction syndrome. So this can happen in a lot of exposure of noxious agents even in non-atopic age. So this should be distinguished from RADS as such. So yes, it's very important, and we tend to neglect it. So and that's why history taking and of course asking you about occupation is very important. I've had patients who were working in a chemistry laboratory whole of the year in college, and they were all exposed to the noxious fumes, and they just never realized that this can be one of the factors. Problem about occupational asthma is that even if we avoid the exposure, it can happen that he may still suffer asthma even if the exposure has ended. So that's the problem about occupational asthma.
Wonderful, sir. So any adult onset asthma, there is you have to take a proper history initially,
Correct.
as it
Yes.
is said that 5 to 10% of adult onset asthmas may be due to occupational asthma. And second thing is in such patients, subtype or phenotype, there is a chance that rhinitis, occupational rhinitis may develop 1 year
Yes.
prior to the onset of asthma. So
Correct.
excellent, sir. And another question coming from Warangal. This is Dr. Srinivas Banod. He wants to know what is hygiene hypothesis in asthma.
Yeah, so I heard about hygiene hypothesis in a lecture which was given by Dr. Peter Barnes way back, and I was quite impressed with it. And this theory initiated from a study which emerged in which they basically studied twins. One was raised in the farm in the rural area, another was in the city, and they and of one that grew in farm actually had less acute asthma, or actually he didn't have any asthmatic symptoms with the one who was raised in city. And this then basically was studied in various studies, and this is there that infection early in life influences development of child's immune system towards a non-allergic pathway, and this then leads to reduced risk of asthma and other allergic conditions. And basically, we can also think in our terms in our country, if you see that in rural area, people and also children play in the dust. So what has been proposed is that this house dust or this thing contains microbial exposure, or also what are called bacterial toxins, which affect their this thing. They get infection in the childhood, and this bacterial infection then basically changes the pathway of these children from this allergic to non-allergic pathway, and they are much. But this is being studied in very interesting, in fact, theory that we see in our life as well. That children who are really raised in city and severe service in our rural area, we find incidences much more in city when we are not letting the child being exposed to any air pollution. He is quite protected, and these are the children who later have asthma attacks. So this is interesting study, which is still being investigated. In fact, but I think it makes sense. It makes some sense, I think.
So in a nutshell, like in our Indian scenario, because we're parasitic infestations and dust mites are common. So we can think that it is like a rich child and poor child type of concept.
Yeah,
So which
so
has
I
reduced.
remember Peter Barnes when, and there was a lot of questions which were answered. And one thing that he said that let your children play in the dust, let them be exposed to all this kind of things. And but I don't know how much it really translates into fact. But this is one of the theory that he was very fond of, and he's the one who actually gave this study to the world, and we had just published a lot of study on this.
Thank you, sir. Thanks for that nice explanation. And there is one Venugopal from Madurai. He is asking about what are the myths and facts about diet in asthma.
Yeah. So you also should realize that we all know that once our patients we diagnose, they would always ask what to eat and what not to eat. And this belief of, you know, cold and hot food is there in our system, in our traditional system, and we try to avoid, telling patients even if you. So it was very interesting. In fact, in my initial years of practice, I know that this thing doesn't happen. I used to say, no, you can eat anything. And then I realized that if you say like that, basically they would just stare at you. So I think that this is more of myth, because if you see the GINA report, it says that food allergy is mostly in children. It is very rarely in adults. So it has been seen, and this food allergy has to be also demonstrated, in fact, by doing upper history testing and allergy testing. But otherwise, you can't just generalize in a way that you can say that you can't eat, like bananas, or you can't eat cold. I think much more actually problem is because of the fibrous content of the fruit, which actually irritates the throat, and then maybe then they just develop cough, and we think that is asthmatic symptoms. What has been proved is, yes, of course, that artificial coloring agent or what ripening agents that you use in fruits, and these days it's quite difficult to get a fruit which is not ripened by an artificial agent. So maybe I think that artificial agents and food additives that are there, those are the offending agents rather than the fruit proper as such. So yes, the myths exist, and basically it is good that you can avoid. So what I said, that there is no fixed pattern of what you should not eat, or what you should eat, but then you should try to just do your own homework and see what really causes the problem, and then you can avoid it later. But not a generalized ban of this thing which is very common in the setup. So, and of course, because GRD and cough is also very common, so these patients I'm telling, they have some of the symptoms of what the gastric reflux. And then when we ask them, we do see that they eat a lot of oil, they use a lot of spices, spicy food, and this itself can cause basically GRD and can cause cough. And basically we can mix these two things as caused by asthma symptoms. So these are two different comorbidities we have with asthma, and of course that has got relation with food. So that is the only thing that in which you have to uh, have some food do's and don'ts. Otherwise, I think you can give. So one thing that my patient and the children, if they ask if they can eat ice cream, I say that you should eat ice cream without any additive, really actually color. So I ask them to eat only vanilla ice cream, because it is not adulterated with any color, because there are artificial colors that are there. So, but then you have to make a way to really counsel them, but because it is quite deeply rooted in our system, so you can't deny, you can't really say that no, you can eat anything. So you have to be cautious and answering, keeping science and also local tradition in mind.
That's excellent, sir. One good thing happened during this COVID-19 pandemic is people are staying at home and eating home food. So these
Yeah.
artificial colors and unhealthy food. So as it has reduced, so we expect that there is some decrease in the incidence of this.
Yeah, so it's already there. I mean, you see that people are saying that we are not getting much more patients of asthma attack, and even if it's monsoon season, I can in fact even say from my experience that we're not getting so many patients. The thing is that our children are locked inside the house because there is no school, They can't go out. They are not exposed to environmental pollution. And yes, there is also what you call a sort of banning of outside food and all those things because they can't go out, so they can't bring it home also. So I think that might be the reason, and this should prove, and somebody should do study really of how many this asthma attacks have actually reduced during this, 4 5 months, and what are the basis of it.
Excellent, sir.
Nice question.
Sir, Dr. Hariprasad from Bangalore, he wants to know about the relation between obesity and asthma.
Obesity and asthma. Okay, so it is related both ways, in fact. So in cases of people who are obese, they've got mechanical changes. They've got pro-inflammatory. It's actually a pro-inflammatory state, and it also leads to increased productions of cytokines, and oxidative stress is more leptin level is high. So all this thing actually basically it also contributes to having asthma, and obesity is an independent risk factor, in fact, which is in GINA report that it's an independent risk factor for having asthma. And these obese patients also have other comorbid conditions, like, as I said, GRD. So they have got a lot of reflux diseases. They've got obstructive sleep apnea, which can confound coexisting asthma. They've got also metabolic syndrome, and it can be other way around, because if patients on high dose of inhaled corticosteroids, who are to be given oral corticosteroids, and who are also sedentary lifestyle, they can get basically obese because of asthma treatment. So it can affect both ways, but it is I think the other way around more than the vice versa.
Excellent, sir. So obesity, because of deconditioning and excessive deposition of abdominal fat and all conditions, we have to really differentiate whether the respiratory problem is due to obesity or due to asthma.
Yeah, so you also raised a good point that females with abdominal obesity have much more asthma incidence than others. So that is one of the points that I forgot is.
Sir, what is the role of macrolides in management of asthma? Because till now we know that macrolides are used in COPD patients, but as per the latest GINA guidelines, macrolides are suggested. So could you please throw us some light on that?
Yeah, so these studies which were done in azithromycin, or it was actually done for azithromycin, we just use a macrolide. And the initial study was done just for 3 months, which straight away said that there is no beneficial effect. But then came 2 or 3 more studies in which azithromycin was given for about 6 months, and therefore definitely have proved that this, of course, reduces exacerbation rate. It is much more for non-eosinophilic asthma than eosinophilic asthma, and the dose it's recommended is 250 mg thrice weekly. They had studies with 500 mg, but they were associated with side effects, so hence it's preferred is 250 mg thrice a week that you can give. And but of course there are some cautions to be also considered when you're using this azithromycin. You should basically have a sputum examination done and see if the patient hasn't got atypical macrobacteria. You should see that patient doesn't have some cardiac arrhythmias or prolonged QTc interval or autotoxicity, and then only prescribe this azithromycin for long period, because as I said, it has to be at least being prescribed for 6 months before any of the result or any of the beneficial result was seen. And as we see that most common side effect of giving azithromycin, especially in high doses, diarrhea. So that's very common. So apart from this, I think what I would and what a GINA report says is that before you actually also will consider this patient for biologics, you should just exhaust all these options, like also azithromycin. So one of the things that they have given, or even if it fails, is this is an alternative to biological therapies. If suppose your patient is not affording, or this you can try, I think, a low dose azithromycin of 250 mg thrice weekly before you just subject him to some costly therapies like biologics. And it has to be given for 6 months.
So azithromycin in stage 4 and stage 5 can be recommended for a maximum period of 6 months.
Maybe stage 5, yeah, stage 5, which you are using high dose inhaled corticosteroids or oral corticosteroids, and you're considering this patient for the biologics, and I think before that, before you try biologics, I think this would be better.
So Dr. Tapas Roy from Calcutta, he wants to know what is the role of montelukast and for how long montelukast therapy can be given in asthmatic patients.
Yeah, so montelukast alone can be given for a prolonged period of time. In fact, the studies that I mentioned in my talk, which say that they had studied this cast for about 3 to 4 years, and then they found that there is some increased suicidal tendency, which I don't know whether it's really, because there are also many studies which says that this was as much as in placebo group. And we know that montelukast is given in a condition like chronic condition like asthma, and all chronic conditions can actually lead to also depression and suicidal thoughts. So I don't know how much that has contributed to this. But problem is that we give montelukast the combination unnecessarily with histamines and histamines. So the combinations I think should be judiciously used, and the combinations are prescribed only for allergic rhinitis, allergic olfactory sinusitis, or organ of nasal polyposis, or these conditions. Otherwise, montelukast alone is a very safe drug, has been given from long period of time. It has been described as an add-on treatment. Before you go to high dose inhaled corticosteroids, you can give low dose or medium dose ICS, and also combine it within montelukast. So this is quite a good drug, I think, but when you're using it in caution, with a combination, you have to be a bit cautious. And now that we got a box warning by GINA, I think we should be also cautious in considering that we just look out for the symptoms of what we call depression and these thoughts if you are really using montelukast for a prolonged period of time. So just have a thought and just include this in your research. Try to probe if some such changes are happening in your patients. I think a word of caution has been given by GINA 2020. As a personal experience, I've been of course using montelukast for a longer period of time, and I haven't found as such any of these problems in my patients when used alone.
So while prescribing montelukast, a meticulous history regarding the psychiatric issues of the patients should be noted of, because there are some incidences of suicidal tendencies also developing as per the FDA. So while prescribing, you have to take a note of the psychosocial and psychological conditions of the patient also. So,
yeah, so it was only one Canadian study which was taken, but it was a Canadian study which included 1,167 patients. So that's why GINA had to take account this study, which actually gave that this might be this cautious things to look for.
Sir, Dr. Vilvanathan from Chennai, he wants to know how can we adopt this GINA recommendations to our Indian scenario.
Yeah, GINA wants, yeah. So GINA report itself says that you have to adopt it to your local needs, because some of the things are not available in your first country. So you have to adopt the local guidelines, and Indian Chess Society and also National College of Chess Physicians, they have got one, of course, guideline on asthma which has to be revised in fact. So, what I told, this guideline was made about, I think, four years back, and we are still to update it, and this is the problem with the guidelines. But there in that guideline, I think in GINA report, there is not much of mention of theophylline derivatives, which we very often use, and this is again an intriguing factor that we always think that Western literature always talks about theophylline in a way that it is quite a drug which is loaded with side effects, and you would find, as you mentioned, it has got a very narrow therapeutic index and all those things. But I think we have been using this molecule since long. Maybe we got some herd immunity against the side effects of this theophylline derivatives. And low dose, I think theophylline, although it is not a good, I think, bronchodilator, but it has got modest anti-inflammatory, uh, effect. And I think I can place it in step 5 treatment or step 4, step 5 treatment. I think before using a high dose inhaled corticosteroid, in fact, I would like to add this low dose theophylline. It should be low dose because it has got side effects of vomiting and cardiac events. So I think low dose is safe and we can use it for prolonged period. And I would like it to be included in Indian, and it is there in fact in step 4 and I think step 5 treatment. So of course, I would say this is a good drug. It should be used in the condition. And the rest of the actually GINA report basically, of course, tells us that Indian we have to basically go for counseling, and it's for everybody that we should not just dish out the inhalers, but because a lot of stigma is there about using inhalers. So if you give it in some other way, other form, they will gladly accept. So these are some of the things that we can adopt. And if you ask me one thing that I want to add for Indian inhalers, it's theophylline.
So Dr. Rajesh Agarwal from Agra, he wants to know which theophylline is better for use in children among the available theophylline.
Pardon?
Acibropyline.
So theophylline, yeah. So as you know, because I said that I will already discuss adult GINA, but I've read, in fact, in children, there is no mention of acibropyline and all those things. These are all pro-drug, in fact, and no mention is there even of theophylline. So in children, there is no mention of these that you should give it in asthma. Although I know that actually many of us basically do prescribe it, but as if you read GINA report, there is no mention of these molecules at all. There is no, at least in asthma.
Yes, sir. Sir, we are in the middle of COVID pandemic, and it is not going to be anywhere around now, and already the asthma season has started. So we would like to know what is the role of teleconsultation in monitoring asthma during this pandemic.
Yes, no, I think webinar can be there without a mention of COVID, so this can't be any exception. And this is COVID has taught us so. I think there's so many things that we can do remotely. And I think provision of personalized healthcare over of course a distance by of course doing telehealthcare is going to come in a big way, in fact, and it is already there in a big way that we are doing a video also consultation, and we can almost do 90% of the things just by talking to people because of the technology that we have. And already we have got smart patient diaries, and they can punch their symptoms and it gets transmitted into an app. So there is an app which is there, which is already available in India by one of the manufacturers. And once you would log into the app, it will give all the information about the patient, and they can record their data about also symptoms. There are also alerts given, and just by reading these peak flow, there are smart peak flow meters. There are actually smart inhalers which can actually transmit the data of how many times they've used, how many, and what was their also peak respiratory flow rate, also reading. So all this thing can be basically collated into a data, and then it can be made into a sort of alert, so that we can actually monitor their treatment adherence, and we can follow them up, and this can actually lead to, it can also facilitate the earliest detection of loss of asthma control, and can also prevent exacerbation. And there are various ways in which you can do these telehealth care things. You simply do a telephone call. You can do SMS. Now we got SMS services. We got video consultancy. We got smart peak flow meter devices. We got smart inhalers. We got apps on our smartphones. So I think this has really made this field very exciting, and we're not going to forget it just till this pandemic, but it is now going to be there in our life for a longer period of time, and it will be quite useful, in fact. So we have just discovered this technology, and there is a vast thing to do with this. So time will tell. We can monitor actually everything. We can do it just remotely.
Thank you, sir. There are lot of questions regarding asthma management that already you have exclusively covered in your session. But I would like to ask one last question before closing the session about where are we in the management of severe asthma with regard with the biological treatment.
So before we, and I told you in my lecture, it is the slide, the last slide in fact, that a lot of things is being talked about severe asthma, which is just about 3.7% of the total load of asthma. But yes, it is important to address because it causes 50% of mortality. There's no doubt about it. But having said that, I think we should consider many of our patients have got many more problems than just this. So before we label them as severe asthma, you have to see that you have just come to the diagnosis very firmly. You have addressed his treatment adherence problems. You have addressed the problem of how to use your inhaler correctly. You have to address various problems of his belief, faith, myths that he has to deal with, and then also the stigma. You have to address his who also morbidities which they with asthma, which can cause this patient to be labeled as severe asthma, and then you have to exhaust and optimize his treatment. Most of the patients that I get basically are just patients who are uncontrolled asthma because of unoptimized therapy, and of this thing would be the experience of all the pulmonologists that these patients are just what could difficult to treat asthma rather than severe asthma. But yes, of course, severe asthma is there. The thing is that biologics are not the cheaper drugs, right? So they're quite costly. Patient has to come to take the injections in the hospital. They have to remain in the hospital for some period of time. It has to be used once in 2 weeks to also months. But you've got availability of I think 2 or 3 biologics which are there, and they are costly. Plus, GINA says that you should at least give it for 3 to 6 months before you call it a failure, right? So at least we should be able to afford this biologic injection for 3 to 6 months. And most, I don't know whether it's covered by insurance, but most of our people, they have this OPD treatment which is not covered by insurance, which is not the case in abroad. They get covered with insurance and they are repaid the amount, but here it's not there. You have to pay from your pocket. So I think considering all these things, you should be really cautious when you prescribe biologics, and it should be almost the last effort before you really say that this you can use biologics, because there are so many things to do before that, and including also you're visiting a diagnosis, and also first is whether you're just dealing with asthma or not, whether you're dealing with something else. Starting from that to your optimizing therapy till step 5 using, I think I would use also macrolides. I would use low dose theophylline in them, and then only I will go for, I think, biologics. That's my take on that.
Thank you, Dr. Rajesh Varnakar. It was excellent presentation from the maestro. Like I have mentioned earlier, the Maharadi of airway management, Dr. Rajesh Varnakar, has given us exclusively all the details about the latest GINA guidelines, management protocols, and also the updates, and also cleared all our doubts. I feel to thank Dr. Rajesh Varnakar, today's speaker, for enlightening us, and I also thank the Chess Council of India for giving us this opportunity, and also CIPLA team for providing us with all the webinar facilities. Thank you, and have a good day.
Oh, yeah, thank you, Dr. Suresh, and I should also mention that I should thank my friend Dr. Krishna, Dr. Narayan, Pradeep, and your soldiers like Dr. Narendra, Dr. Vijay Kumar, Dr. Ravi. You have been just doing what we call a fantastic the job at CCI. Keep on just doing that, and all the best to you guys. You're just rocking CCI like anything. I'm quite fond of your activities, and keep on doing this good work for our younger people. And I also wish you all the best. And of course, till we meet, just stay safe. Thank you. And thank you, Dr. Suresh, for your kind words. Thank you.
Thank you, sir. Have a good day.
Thank you, and stay safe.